Hello, this is Jeremy Faust, editor-in-chief of MedPage Today and author of Inside Medicine. Today, we're joined by Dr. Joseph Allen. Dr. Allen is director of the Healthy Buildings Program and an associate professor at Harvard's T.H. Chan School of Public Health. And he is just the air quality guru for before and after the COVID pandemic. His book is called Healthy Buildings. He is the chair of the Lancet COVID-19 Commission Task Force on Safe Work, Safe Schools, and Safe Travel. Dr. Allen, thanks so much for joining us.
Yeah, it's great to be with you.
So the White House, that was the last time we saw each other. That was the first time we met in person, actually, was at the White House. Very cool, right? And it was for your event, this Air Quality Summit. How did that come about, and what was your big takeaway from that?
It was a major event at the White House, and I don't think it's overstated when we say it's a landmark event in terms of what this means for buildings and ventilation. I mean, the White House, right? The biggest bully pulpit in the country thought it was important to have the first ever summit on indoor air quality. I've been in this field for a long time. It's a relatively small field. I think I know most of the researchers around the world who are doing this. It's a small group relative to other fields. And to see this at the White House was, I had to pinch myself, honestly, a couple of times. I think it's a watershed moment because so much of how we operate, design our buildings determines our health. And this message is now breaking through in a big way. And I give credit to Dr. Ashish Jha and his team and White House Office of Science, Technology Policy for really elevating buildings into the national strategy around the COVID response.
It was interesting to me being in that room. I was like, actually, of course, I was happy to be invited, but I was actually a little confused. And it was because I'm not an air quality guy. And you look around the room and you meet who's there. And it's a lot of scientists, a lot of researchers, there's a lot of people in OSHA space or in technology space. And there were probably 3 medical doctors in the room: Ashish Jha, me, and Celine Gounder. I didn't see any other MDs. And I was like, we were there to sort of be flies on the wall. And I actually thought that was emblematic. There's still this disconnect between people who are talking about this as a sort of a healthy workspace thing, and then physicians who we prescribe things like physical therapy, or we prescribe things like cardiac rehab or medicine, but we don't prescribe things like open the damn windows. So I'm just curious, whether the fact that there was just 3 of us there was sort of emblematic of the problem, or just progress, that it wasn't 0.
Yeah, no, I take it as progress, and I hope eventually you do write scripts for Open Your Window. But here's where I saw this progress, right? It was a relatively small group, right? Maybe, I don't know, 50, 70 people, something like this. But as I scanned the room, I saw the same thing, right? So I saw a lot of my really trusted indoor air quality colleagues: Rich Corsi, Lindsay Marr, Shelley Miller, people I just know, and they're really good. Then I see the MDs who I know are really good. And then you look around the room and you had representatives from not every agency, but agencies that are critical in this battle: EPA, CDC, NIOSH, Department of Energy, right? Department of Education. So you had all the representation from important agencies, and then you had business represented, you had technology and innovation represented, and you had community groups represented, like my friend Carl Howell, who presented about all the work they're doing at community teamwork around in shelters and things like this. So I thought the mix was actually really great. And it's also why I think it stood out from other meetings. I've been in a lot of meetings where it's a lot of us indoor air quality scientists saying the same things we always say for the same, we say it over and over. Probably the MDs do the same thing. And it felt, this kind of mixing was really important. And I've had great follow-on conversations since. So I take it as a positive and progress, that it seemed like out of the 50, 70 people, whatever it was in the room, we had a mix: policy, medical, scientific, building science people, community. It was really terrific.
Yeah, and I'm trying to sort of sort out from that, what is the sort of clinical effect that we might expect to see? So I actually, thanks to you and others, I followed up with some of these people who were in the room, and actually some of the business groups are really where there's an untapped resource. There's been sort of, they don't really quote study it, but they kind of in a way could. And to get an idea of if you do what people like Dr. Allen tell us to do, or Lindsay Marr, whoever else is out there, what will happen to your business? Will you have fewer sick days? Will you have people actually healthier and better productivity? I'm really trying to sort this out. I know there's not one answer because there's a million scenarios, But like, what is the sort of clinical effect that you would anticipate, say for like a school, if they, take two schools in a parallel universe, one with 30 kids in each classroom, and one of them has good filters and good ventilation and one doesn't, and take me through a flu season. Like, what difference would the two feel like?
Well, I think the evidence here is really deep, that whether you look at schools, offices, whatever, I'll take your school example, that you're going to see these multiple benefits of better ventilation, better filtration on things like you just mentioned. We see impacts on math scores. We see impacts on reading comprehension. We see impacts on concentration. We see reductions in asthma attacks. We see fewer missed school days. And so if you look across all these studies, and across respiratory diseases or viruses like SARS-CoV-2 or influenza, you see the relative risk difference. Let's say studies showing a twofold relative risk decrease with higher ventilation and likelihood of getting influenza. You could take this really in terms of impact on student learning. You could take some of these really big studies on learning or reading comprehension. You see differences in 5-10% differences in math scores or reading scores just by minor improvements to ventilation. I'm not talking like, some multi-million-dollar fix to the school either. To your point, open up the windows a bit more, get these ventilation rates higher. I think this is one of the challenges, and I just talked about this with the group yesterday, of our Lancet COVID-19 Commission task force on safe work, safe school, and safe travel, put out a report this week on new proposed health-based targets for ventilation. And people ask that question, well, what's the percent benefit I'm going to get? Well, I think, as you know, with COVID, it's really hard to say. It depends on the population, the mix of vaccination, age, waning, all of these factors, prior infection. But I think we can think about it similarly how we think about masks or other things, right? So N95, what's that going to do? Reduce your exposure by 95%. Simple stuff, right? Same thing if you think about air changes per hour. If you hit our targets, you can reduce exposure by 95%. So early on in the pandemic, we talked about this. Simple masking, ventilation, filtration, even prior to vaccines, you could quickly reduce exposure by 95% or more, actually closer to 99%, just for those things, masking and ventilation, prior to the vaccine or anything else that we have going, any distancing. So anyway, it's a long-winded answer. The short answer is we have a report from the Lancet COVID-19 Commission on schools, and in the table in the back, it talks about the multiple benefits of ventilation and lists at least 10 different studies where we report the relative risk and what these studies found when ventilation was approved across these different dimensions of concentration, reading, infectious disease transmission.
Two questions on that. One is, how much of this is a cumulative thing? In other words, you take one school that didn't do it and one that did, and check a year later, versus like literally like the same day, like, oh, there's a flu outbreak, like, open the window, bring in that extra air filter. Like, how much of it is like just immediate proximal risk as opposed to like a cumulative risk exposure? Like if you live in a city that's got a lot of pollution, you're not going to do as well as if you live in clean air.
Yeah, I think it's both. And there's some our team at Harvard put out some new studies on acute effects of ventilation and reductions in particles on immediate impacts on cognitive function test scores. So we follow these people all over the world at their office desk. You put an air quality monitor, you give them a cognitive function test. The particle levels, outdoor air pollution, and the CO2 levels in that moment have an immediate impact on your performance on cognitive function tests. So it's immediate. If you think about the more longer term or chronic, these cumulative effects, well, a risk is a function of exposure's intensity, frequency, and duration, right? So you keep reducing your risk over time of catching any or all of these viruses that are circulating each time you have the higher ventilation rate. Definitely, if you're having an outbreak in a school, take this measles outbreak that's happening right now, right? Of course, number one strategy, vaccinate. We wrote a paper last year, 2 years ago, also showing that ventilation, of course, lowers the risk of measles. The first thing they should be doing right now, while they have the vaccine campaign going, get those windows open, get the portable air cleaners with HEPA filters. Like, these are things that can be done today. Anytime you have this immediate acute thing, hey, kids in class have this, you have 2 or 3 kids that have that got COVID or have influenza, well, take these steps to reduce the risk in the moment too. So the ventilation and filtration benefits are both in the moment, but also have the longer term benefits as well.
All right, let's do an extravaganza on these things. This is I got one of these. When my kid got COVID, I did what everyone wishes they could do. I called Joe Allen, and you told me what to do. And I will say, it's N of one, it's anecdotal, but I got a household with an infant, a 4-year-old, and 2 adults, and the 4-year-old got it, and none of us did. Now we're fortunate; we have resources, we have space. It was summer; we could open every window. But it was. But this is when I got this thing, and I learned a lot from this. And people have questions about this, and obviously it's a portable CO2 monitor. This one's a couple $100, $200, and it's a proxy for how good the air quality is. It's certainly a proxy. It's definitely a proxy for COVID exposure. It's just CO2. It has nothing to do with that.
So we know ventilation filtration are good for reducing risk from COVID. We now have these relatively cheap tools. I have the same monitor here. I'm holding up. I have 3 or 4 behind me connected in. I test them all out. We now have the ability to make the invisible visible. So how do you know if air quality is good in your space? Well, I don't know. How would you know? If it feels stuffy in here, I don't know. But now you have a monitor. It's a really useful tool and a quick proxy, a quick way for people to understand how well is your space ventilated. And to put some numbers on this, typically my field has thought for a long time, if it's under 1,000 parts per million of CO2, that's typical ventilation. We like to see less than 800 parts per million. But there's another catch. We're talking a lot about ventilation filtration, right? CO2 is only telling you about outdoor air ventilation. The filters you might use in a HEPA filter, your portable air cleaner, aren't capturing CO2. So if you have low CO2, you're in good shape. If you have high CO2, doesn't necessarily mean it's a bad, because you might have a great filter game going.
Let's talk a little bit about mitigation. And again, I like the idea of giving people something that they can use. When someone goes home for the holidays and they, of course, we would recommend rapid testing before you get together with people, especially vulnerable people, masking when you can. But what difference would it make, just something as simple as opening the windows for 15 minutes an hour? Because I noticed when I was driving my car recently, I had my CO2 thing, and opening the window, it was an immediate difference. It was unbelievable, the difference. I get it's proxy, but the point is that it didn't take long, even with a crack of window open. So if like people don't want to like really be disrupted, and you just said, look, just open the window for like 15 minutes an hour, 10 minutes an hour, even if it's cold, just that little bit. What kind of difference does that make?
Well, it makes a massive difference, and you see it in the car example. I mean, Rich Corsi, Jack Spangler at Harvard, and I wrote a piece in April 2020 saying, like, people worried about getting in cars or Ubers. We model, you crack the window an inch or two, you see it in the data. The CO2 drops, it starts to look like outside. You get lots of air movement. Also, what happens when you're in a car for too long with a lot of people, windows up, you get tired, right? That's ventilation. You're not going to get enough ventilation. So same thing happens when you're at home, or I do some simple things, right? Everyone, my family's vaccinated, boosted, updated on our boosters. We're doing good on that front. I think our risk has largely dropped. Risk of severe disease has largely dropped, but it doesn't mean we don't want to get it. So we're not wearing masks when we gather, but yeah, we cracked open the windows just a little bit. I mean, do an experiment. Someone could take that CO2 monitor in their office, crack open the window, or let it build up, let CO2 build up, then open the window and see what happens. You'll see it drop really quickly, and quickly you'll see it drop under the 1,000 parts per million level. You'll see it drop under 800 parts per million. And that's a really good indicator. They don't even have to be thinking about the filtration effects. If your CO2 starts dropping under 800, got the window cracked a little bit, you're in really good shape. Yeah, because our homes actually are really poorly ventilated across the board. Yeah.
All right, thought experiment. Let's say that you take the worst right before Thanksgiving, right during Christmas, New Year's, and maybe January, and you require every school to open the window in the classroom for 15 minutes an hour, every nursing home to open the window 15 minutes an hour. What do you think the reduction in morbidity mortality from flu, RSV, and COVID would be just from that?
I'm not sure I'd go the 15 minutes an hour like fully open. I would even take just crack it a couple inches and get some baseline changes. I'll put some numbers on it. Let's say school's getting 1 air change per hour in these tight season, right? And by opening up the windows or making sure the ventilation system is working, you get it up to 3 or 4 air change per hour. You have a 4-fold reduction in exposure. Immediate, right off the bat. That's massive. Look at some of the modeling we did with the New York Times in 2021, which I think was really helpful. It was a visual of we did tracer gases essentially from people's breath, and it fills up a classroom. And what happens when you open the window, put an air cleaner in? You see that, yeah, the person's still if someone's infectious, they're emitting still, but they can no longer impact somebody on the other side of the room. In other words, you can't have a 90% attack rate like we were having early in the pandemic. It's diluted too much. Yes, people can get sick, anything can happen, but you're reducing the risk dramatically from these simple steps. I really think it's critical. One, I like where you went. I think it's important to focus on those at most risk of disruption. I think kids in schools, and those most at risk from severities of severe COVID, and that's people who are older. I think we need a lot more attention on senior living, congregate care, where I don't know if all these ventilation filtration recommendations have really penetrated. You want to make an impact. You see the curves going up right now from hospitalizations. It's nearly entirely all in those over 65. In addition to vaccines boosters targeted towards this group, the ventilation filtration improvements, this would lead to the biggest benefit right now related to COVID. Doing this more broadly, including schools, would lead to a bigger benefit in terms of COVID, RSV, and influenza.
All right, last question. This is, you have two audiences, really. You have the individual and you have sort of like the big systems. And sometimes I think about these questions in terms of like, oh, well, my carbon footprint is a drop in the ocean because, one company, does 100,000 times more than I ever will. So whether I like recycle this Coke can or not, this really doesn't matter. Do you think the solution is sort of really wrapped up in sort of the big picture, this almost like the friction-free stuff? Like, it's already, the decisions have been made for you. You go to a school or a business that has good air, as opposed to like what you do at home is just sort of a drop in the bucket. Like, who do you think bends this curve more, the individual or the system?
Well, we need a system-wide approach, and I'll tell you why. The message is starting to get out there, but you look at who's making the changes. It's like always, it's well-resourced individuals. It's well-resourced schools. It's the big companies. They're all doing this. I'm not worried about them, right? But if we don't codify this, and by this, I mean the current ventilation targets are too low. You will find widespread agreement on that. They're not health-based. If we don't set new standards and new codes based on health-based benchmarks, it's not going to hit everyone everywhere, and the disparities will widen even further. So yes, I'm heartened that we have a big focus here, but this is a huge equity issue. And until it just gets built into the codes for buildings, right? You don't want to think about it. I don't want to think about it. I just want to be in a healthy home. When I go to the store, I want it to be a healthy place. My office should be a healthy place, right? It has to be built into the codes. And right now, code is based on these bare minimum ventilation standards. The standard is called the Standard for Acceptable Indoor Air Quality. It's not acceptable. Decades of science are showing it's not acceptable. We got this virus spread entirely indoors that is slammed up against a building architecture and design that's been designed without thinking about health. And so it's no wonder we've had the disaster we've had. And if we come out of this where healthy buildings are confined to only those people with the resources, it'll be a gross, gross failing, gross in all meaning of the word. So I see some movement happening, but this is where my field and everyone else needs to keep pushing. We have to change the standards so that it just becomes the norm. It just becomes the norm.
Joe Allen, thanks so much for joining us. Your book, Healthy Buildings, is also extremely interesting reading. Thanks for joining us.
Yeah, thanks. Enjoying the conversation.